The following was recorded at the CCHF Conference 2023 in Cincinnati.
Thank you. So continuing education, especially with APA, please make sure you sign in on that sign-in sheet so that we know you are here. And then for integrity purposes, we ask that if you actually claim credit for it, that you were here the entire time. We're asking to make sure you stay the whole time. Okay. All right, so I'm Tracy Frame, and I have two locations on here. So my job that pays me is Belmont University, and I work in the College of Medicine there. So we are up for a site accreditation visit this summer, and we will see if we're accredited, and if we are, then we will hopefully be able to take students in the future, but can't say that we are yet. And then I came from the College of Pharmacy at Belmont University, so I've actually been at Belmont for about 10 years. And so I recently transitioned to the College of Medicine. In addition to Belmont, I work at the next door, so I work over there as my clinical site. So when I was in the College of Pharmacy, I was there about 50% of the week. And so let me talk a little bit about the next door in a second. I have nothing to disclose, and then I also have no conflicts of interest today. So my objectives of the day are to review the medications used in medication-assisted treatment, consider the special considerations one should understand when providing or dispensing medication-assisted treatment, or MAT, and discuss the importance of building trusting relationships with patients on MAT. So just a little bit, like I said, I would say something about the next door. So a little bit about the next door, because this is where my talk comes from, because it works with women in addiction. But their purpose is that we exist to empower women for lifetime recovery. We provide all kinds of care, which I'm going to talk about on the next slide, but really trying to also integrate an environment of faith and healing to restore hope and lifetime recovery for patients. We use a model that integrates 12 steps. We use faith and evidence-based practices to address the needs of the whole woman, so mind, body, and spirit. So these are the services we do provide. So we do inpatient treatment. So we do medically monitored detox, especially in our patients that are coming off of benzos, alcohol, even opioids. We're going to provide treatment for them there. And we also do residential treatment. So typically people can come in and just do detox, but most of our patients come in and do detox and residential. And our residential program is about 2 to 4 weeks. So really, we're just basically stabilizing them physically, and then we're trying to get them set into a longer type of treatment program. We do also do outpatient treatment programs through the next door as well. So we do PHP, or partial hospitalization programs. So people are typically there about 6 hours of the day. So they are there, and then they go home, go to meetings, go to sleep, come back the next day. That's a lot of times for our people that we just aren't ready, or we don't feel they're ready to go out and only do a 3-hour-a-day program, but their insurance won't cover them to be in treatment full-time anymore, so we do the PHP program. And we also have the IOP program. So again, this is about 3 hours a day. And it just depends on payment and how long people are in that, but we do that. And then we do what we call the recovery care clinic. So that's typically where I'm going to talk a little bit, probably more today. The recovery care clinic is kind of like our outpatient clinic that helps women, and we provide MAT and so forth. We also have alumni things that we do, lots of alumni events that are always happen. They have an actual T&D app for alumni that they can get on, and gives them encouragement and so forth. And then we have reentry programs, so incarceration back into the community as well. So that's actually a program down in Chattanooga. It's a facility that helps women. They're in prison, but they actually go out and get a job and like all kinds of stuff. It's a really, really cool program. So kind of quickly to kind of go over medication-assisted treatment in opioid use disorder. So I wanted to quickly talk about the medications. So I don't know, is everyone in here familiar with the medications of MAT and how they work? So let me quickly kind of talk through them. So when we talk about MAT and opioid use disorder, we have different types of medications, and they all have activity at that mu opioid receptor, so the receptor that provides the opioid effect, right? So we have full agonists, partial agonists, and antagonists. So our full agonist is methadone, our partial agonist is buprenorphine, and then we have our antagonist, which is naltrexone. We have naltrexone and naloxone. So naloxone I put on here just because people get that confused a lot. But naloxone is really what we use in overdose. So it's not used as part of like a treatment plan for patients long term. So that's kind of the difference there. We're going to talk about each of them. So methadone is our full agonist. So it binds to that opioid receptor and it causes a full effect, right? It's a full opioid. So that's very similar to oxycodone, to heroin, to fentanyl. They're all full agonists. So methadone is similar. The difference in how it's used in MAT is it's long-acting. People have to take it once a day, but it's not multiple times a day. It obviously is an opioid, so it also provides that opioid effect, and it can kind of help prevent cravings, though, because it's not an up and down, it's long-acting. It typically lasts 24 to 36 hours, and then it goes and sits in the fat, so it takes forever for it to come out on patients. So patients that are coming off methadone, it takes a really long time, so you're going to see withdrawal for a while. It takes about 5 days to reach steady state, so you really start low when you dose this, and you kind of go up really, really slow with the patient. And then we individualize dose. That's really important. Adverse effects, typically what you would see with any type of full opioid. So you can get sweating, you can get constipation, that's a huge one, urinary retention. Also we see like respiratory depression, right? So just like heroin, you can get respiratory depression with methadone. That's why you have to go slow as you kind of introduce it to the patient. It's what I would say a pharmacist might call a dirty drug. So it has lots and lots of drug interactions. It has lots and lots of side effects. You can see arrhythmias, you can see interactions that cause arrhythmias, all kinds of stuff. But we do see some of that here. If they take too much of it too and you go too fast, you can cause overdose. So again, that's why we go slow. Buprenorphine is a Schedule III controlled substance. It has what we call a ceiling effect because it's a partial agonist. So what it does is it binds that opioid receptor, and it doesn't cause a full effect, but it causes a partial effect, right? So it still activates, so it still has some activating opioid features, but it only does it to a certain extent. So it has that ceiling effect. So you will only get so much euphoria, or you will only get so much respiratory depression. So really it's got that protective effect with the respiratory depression. We use this when we help people come off of opioids, and then we also use it in maintenance. We typically start at 12 to 24 hours after the last opioid, or what can happen is you can send a patient into withdrawal. So if someone has just used heroin and they come in and you give them buprenorphine, you've given them a full agonist, and now all of a sudden you give them buprenorphine, which is a partial agonist. Remember, so like full effect, partial, half effect. So what you're going to do is you're going to send them straight into withdrawal by giving it too early. So it's really, really important that you initiate based on how the patient's, what we call scoring, so clinical opioid withdrawal score, what they look like, what are their signs and symptoms, are they going into withdrawal, but you don't give it too early because then you will send them into withdrawal. It also has a long elimination half-life, so it takes a while to get out of the system as well. So patients can take it, and then it will take a little, I've seen patients probably 3, 5 days, 7 days in that are now starting to have withdrawal after coming off of buprenorphine. So different types of products. So Subutex is just our tablets that have just buprenorphine in them. Then we have the next 3, which are buprenorphine that have naloxone component. So you do it sublingually because what happens is if you just take it by mouth and swallow it, the stomach just kind of gets rid of it. So that's why you have to put it under the tongue, right? So it's really important that these are given under the tongue. Then we have Probufene, which is our 6-month subcutaneous implant. And then we have Sublocade, which has kind of come on the horizon recently. And it's actually, it's showing really great results in our patients. But it's a monthly abdominal subcutaneous injection of buprenorphine. So common adverse effects, big one that I would say is the one that we see the most probably is actually swelling. So we'll start patients on it and they'll have a little bit of swelling. Now if it becomes significant, a lot of times that actually means the patient probably won't be able to be on it long term. But we do see, I'll tell you, like most of the patients that start on bup, they'll all of a sudden have a little bit of swelling. But again, if it's significant swelling and we can't get rid of it, then a lot of times it's not going to be a great option for that patient. But other than that, like I would say, really people respond to it pretty well. Again, it is an opioid, so our patients are have opioid use disorder, so it's going to be helpful for most patients. Ultimately, a lot of our patients with these side effects, like they're already using opioids, so you're not gonna see probably a lot of the sedative effects that you might see in one of us that's taking it or takes it, or a child or something like that. So you don't see a lot of those unless they take way too much of it or they really weren't taking what they said they were taking of opioids. So I did want to mention that the removal of the X waiver happened recently. So this basically just means that practitioners, they don't have to have a specific license to practice and dispense buprenorphine. Now this was removed recently, but I will say, like, make sure that you actually look at your state law, because state laws can actually kind of trump that a little bit, and they can have specific requirements. So making sure you look at your state law, but now it's really just trying to increase access. So it doesn't have to be a specific MAT provider, but actual other physicians in the community can prescribe buprenorphine as well. And last but not least, naltrexone. So naltrexone comes orally or it comes as an injection. So it really helps reduce opioid cravings, but what it does is it binds and it blocks that receptor. So it's called an antagonist. So there's really no opioid effect, right? It binds and blocks it, but it doesn't cause any opioid effect. Thereby, because of that reason, it's not an opioid, it's not a controlled substance like the other two, right? We don't see withdrawal when people stop it because it's not causing an effect there. It's just blocking and binding that effect. So the really great thing about this one is that people that don't want to be on any type of substance that's causing an opioid-like effect can potentially be transitioned to something like this that might make them feel happier. I think that's, yeah, so no euphoria, no sedative effects, nothing like that. So side effects, really the biggest one we see orally is nausea and vomiting. So I will say that, like, just because somebody takes it by mouth, that's a super common side effect. Of course, it's going straight to the gut, right? But if they get the injection, a lot of times they won't have that nausea and vomiting. So I think that's a really key point. And like some of our patients are like, oh, I feel terrible after I took that. And we'll have to say, well, if it works and it's working for you, if we give you an injection, you probably shouldn't have any of that nausea and vomiting. We don't really see that as a side effect. Really minimal drug-drug interactions. Injection site reactions, just as you would with any injection, but it is a pretty large injection. So you just got to make sure that if they had any serious redness or swelling, anything like that, like an abscess that occurs, then we obviously have to get that treated. But ultimately, it's a really great drug. Liver stuff, we really don't worry about it. If their liver enzymes are less than 3 times normal, we can go ahead and start it, but we just monitor liver function. But if they have severe liver impairment, something like that, that's when we would have more concern of starting something like this. All right, so a quick question. A patient's last use of heroin was 4 hours ago. They tell you they feel terrible and want to know what might help. Which of the following would be most appropriate to tell the patient? The bupe should be started immediately to help with withdrawal and cravings. Naltrexone should be started in 1 day since heroin is short-acting. Patient should be started on 100 milligrams of methadone as soon as possible. And the patient should be monitoring using the COWS score to determine when bupe might be best to initiate. What do you think? D, good job. You guys are so smart. So A, obviously, like I said, we don't really start buprenorphine right away. We really want to look at that COWS score, right? So are they sweating? Are they having muscle aches and pains? Are they having nausea, vomiting, diarrhea? All of these, is their blood pressure going up? All of these things we want to see, and we typically want to see people hit a COWS score probably at least 10 to 15. If they've been using fentanyl, we like to push it a little bit higher because you have a higher chance of sending them into withdrawal. So we're going to really try to make sure that they're hitting a COWS score that's showing that they're actually in withdrawal. Again, otherwise you're going to give it and you're going to send them into withdrawal. Naltrexone should be started in 1 day. So naltrexone, really, we have to wait, typically I would say 7 to 14 days before you start naltrexone. Sometimes we start it a little bit earlier in our patients, but again, it's going to bind and block. So if there's any opioid in the system, if it goes in there, it's going to knock whatever it is. If it's buprenorphine, if it's heroin, if it's fentanyl, it's going to knock it off and it's going to send them straight into withdrawal. So we really have to give them time and make sure that's flushed out before we would start something like that. 100 milligrams of methadone is way too high to start on. You potentially could cause respiratory depression in the patient. And then obviously monitoring that COWS score, like I said. So we want to really keep an eye on that to kind of determine when it's going to be best. All right, so trying to talk through some special considerations. So I worked with my providers on this presentation. So Our medical director was hoping to be here, but he couldn't be here. So he's the one that really sees a lot of the patients. I obviously help and see a lot of patients as well, but not as much in the outpatient clinic. So he and I worked on this together, and I'm bringing some of his special considerations here. So why in the world do you treat opioid use disorder with an opioid? This is a very, very common question, right? So I wanted to basically talk quickly about the overall impact. So I think when we think about why do we treat opioid use disorder with an opioid, obviously we think about like patient retention and treatment. That's great, right? They're gonna show up to get their medications. But also we think about, honestly, the lower rates of opioid overdose. So if we decrease the rates of opioid overdose, obviously that lowers the rate of death, okay? So we see that it's actually been proven to cut overdose death rates in half, giving patients something like buprenorphine. Also obviously lowers healthcare costs. I do think the criminal justice system, I found this very, very interesting, but it can reduce recidivism rates with access. So if people have access to MAT in incarceration, it actually decreases their chances of coming back into prison. It also has shown that it's 129 times that of the general population. So people overdose and die when they leave prison without MAT treatment. More than general population, like 129 times more than that of the general population, which is astronomical. And then Rhode Island actually did a little thing where they implemented MAT for opioid use disorder during their incarceration, and overdose death rates dropped by 61% after relapse. Again, preventing people from showing back up in prison, preventing people from going out and dying. All of those things are going to be obviously hugely, hugely important and impactful. And then ultimately, if we treat opioid use disorder with an opioid, we're gonna see stuff like infectious disease go down, right? Like risk-taking behaviors are gonna significantly decrease. So the rate of HIV, the rate of Hep C, hepatitis B, all of those things are gonna go down. Even we talk about endocarditis, we get so many women that have used dirty needles and show up with endocarditis from our clinic, from the hospital, right? And so decreasing that rate because we're treating them with something so they're not taking risk-taking behaviors. So pregnancy, I wanted to quickly talk about this. So this is kind of some new information out there as well. So it's always kind of been, there's a couple studies out there that showed people had babies that were born at stillbirth or died. And so everybody's always said you can't get women off opioids in pregnancy, right? It's too risky. But there's some big studies that have come out by Dr. Towers, and he actually shows that there are positive results when we actually detox women from opioids in pregnancy. And in his studies, he didn't show any significant increase in intrauterine fetal death or preterm labor whenever you got women off opioids in pregnancy. Also, getting them off of it decreased neonatal abstinence syndrome. So when a baby shows up in the ICU from the mom using, and then has to be in the ICU for however long, being titrated off or being given medications to help with withdrawal. So we see that obviously decreases if we can get women off of drugs in pregnancy. There are some concerns, obviously, when we get women off though. So the big concern is pregnancy, like not using while pregnant for the rest of their pregnancy, right? Like that's a huge concern. And then there's a risk of relapse in pregnancy, right? So if they do use again in pregnancy, that can ultimately lead to death of the mom because she's been off of opioids now and now she's using again. So we have that risk. And then ultimately the other risk that we see with just use in general, like infectious disease, overdose, death. I will say, I did put this on here, there's limited data regarding like maternal and neonatal outcomes beyond delivery. That's for both not using opioids and using buprenorphine in pregnancy. We don't have enough long-term information out there about that yet. So I don't want to make any statements about what that's going to look like, but we do know that in pregnancy, it can be safe to get women off if they want to be taken off. So is it risky to treat a patient? So like I just kind of talked about all of this, the risk of being untreated can result in all of these pregnancy complications, right? We have women that have come into us and they're 38 weeks pregnant, and they've been using heroin the whole time. So they're up and down, right? Like the baby's kind of in utero and we don't know what's happening per se. Heart rate might be going up, all that kind of stuff, right? And so I think also thinking about like if we're not treating women. So if a woman really, really wants to be off, we have studies that show that like it can be safe to get her off. But if we're not sure or she's not sure, then really probably looking at like the risk of not treating her when she's pregnant. So when we talk about like what should we treat pregnant women with when they're pregnant, first-line medications are methadone and buprenorphine. And obviously I want to like hit home on this. I am a pharmacist, but in addiction, really we don't just focus on medications. That is not the cure-all at all. Are they helpful? For sure. Can they help people get it back on their feet? Absolutely. But we have to think about the wraparound, right? Like the counseling, the behavioral therapy, helping them find places to live, right? Getting back a support system around them, going to meetings, getting involved in church or a faith community. Like all of that is huge, huge importance in a patient. So really talking about that. But when we do see that we give them medications and we provide therapy and counseling, all that kind of stuff, we do see like pregnancy complications go down. So they have a longer pregnancy, they stay in treatment, then they can be treated when they have the baby, right? And so all of those things are super, super helpful to these women that are struggling during this time. Which ultimately all of this is going to decrease our cost on healthcare system, which is really good as well. So last but not least in pregnancy, naltrexone, since I talked about the other two. So what do we think about naltrexone? So again, this is kind of new on the horizon, and it's kind of been some information coming out about this. And this is also Dr. Towers. So he kind of, I met him probably 8 or 9 years ago, and he was already kind of going against the grain, I guess, a little bit on like what everybody was saying. But he's starting to publish some of his results. And with using oral naltrexone compared to buprenorphine or methadone, again, naltrexone's an antagonist, so we're not going to expect to see any withdrawal, right? So we did see that result, but neonatal abstinence syndrome in the baby was significantly lower in the naltrexone group, so 10 out of 119 women versus 79 to 105 of infants that needed care with buprenorphine, right? So again, I think this shows that like, and he also showed that really there was no difference in abortion or stillbirth in either group, no changes in fetal heart monitoring whenever they started naltrexone, there were no difference in fetal anomalies, and then no maternal relapses occurred in the 7-day no treatment window. So when they got the woman off of opioids and transitioned her onto naltrexone, they didn't have any women that had overdosed or relapsed during that time. So again, this is a huge like, especially for our women that really don't want to be on anything. This can be really, really helpful. Oral naltrexone every day can help prevent those cravings, can allow them to kind of function without thinking about it all the time and be able to really have a healthy pregnancy. So other special considerations. So if you work in an MAT clinic, you'll hear a lot of women say, oh, I have an allergy to buprenorphine and naloxone. And so we'll always have to kind of ask more questions, right? So making sure, like, is it an actual allergy or is it actually they went into withdrawal because they took it too early, right? So those are important questions and things you have to distinguish. So allergy incidence overall with naloxone, and this was based on studies that use naloxone for overdose, but basically it showed it ranged from 0.2 to 3.6 of patients who arrived to the emergency department after overdose. So a very, very low percentage of people that have an actual naloxone allergy. Typically, I would say if you do have some type of allergy, you're gonna see it within the first 4 hours after they take it, maybe up to 8 hours, but overall, you're gonna see it pretty quickly. Precipitated withdrawal, on the other hand, occurs if you give that bube too early, and basically it kicks the body into withdrawal. So patients experience withdrawal symptoms, and withdrawal symptoms are typically your flu-like symptoms, right? Muscle cramping, sweating, nausea, vomiting, diarrhea, feeling super, super anxious. So if that's what they're describing they had with it, that's probably more they took it too early and it's withdrawal versus some type of anaphylactic, can't breathe, rash everywhere kind of reaction. Does that make sense? Okay. Other things we think about outside of that is buprenorphine induction. So one of the big things we're seeing, and I will say, golly, most of our patients actually come in and their urine tests positive for fentanyl, even if they didn't think they ever were taking it. Even our patients that are taking meth, it's being laced with fentanyl. So we're seeing this pretty consistently across the board. So really we have to be really careful, even in our patients that said they use meth, if their urine panel shows that they have any opioids, most likely it's gonna be fentanyl. We really got to make sure that we're initiating it appropriately, right? Because you can send them into withdrawal. So again, we're going to wait until the patient's experiencing mild to moderate withdrawal. I told you a little bit earlier, we typically push our CAL score a little bit more on fentanyl because it also sits in the fat stores, so it takes forever for it to come out. So really, if you give it too early, you're going to send them into withdrawal. It's this really interesting happy medium, right? So you got to find, make sure the patient's actually in withdrawal and they're not overexpressing what's happening, and then making sure that we give it to them before we would allow them to walk out the door. So we have a lot of patients that will say, if you don't give it to me, I'm leaving, right? And so we'll say, okay, we think maybe you should wait a little bit longer, but we don't want you to walk out the door, right? And so we'll give them what's called a test dose. And typically that's a 1 milligram dose, so a low dose. And then we'll wait an hour. If they don't have any symptoms, we'll give another 1 milligram dose. And if they're still good, then we start them on a taper if they're wanting to come off, or on treatment if we're going to use it as treatment. But really making sure that we're looking at them, the patient, and what they look like and their signs and symptoms before we would start it. We do urine drug screens to see if they haven't really shown a lot of withdrawal symptoms and they say they feel terrible, we'll do a urine drug screen, but it's really based on a lot of times what we see with the patient versus what the urine drug screen says. So like I said, to give or not to give, we always give a test dose. If they're going to walk, I would much rather give them a test dose. If they're already in withdrawal and they're going to go back out and use, right? I would rather give them a test dose before they walk out the door than allowing them to walk out the door, because they're ultimately walking out the door to a relapse. So microinduction is kind of that. It's administering small doses of buprenorphine slowly with gradual increases in dose and frequency while patients are still using that full opioid agonist, right? So if we were trying to switch somebody from one to the other, that's what we call microinduction. So this is relatively a new idea. The hard part of this is buprenorphine naloxone is only made at 2 milligrams as the lowest dose. So it's hard if you're supposed to do it in the hospital to call down to the pharmacy and be like, can you give me 1/8 of a tablet? You know what I mean? It's just, pharmacies are probably not going to be the happiest about that. It's not the best idea. So it's harder to do. It's easier to do for a patient to say take 1/8 of your tablet at home, right? For a prescriber to do that. So we really just want to make sure, basically we're overlapping buprenorphine and the full opioid agonist. So we're kind of slowly increasing that partial agonist while the full agonist kind of goes out of the system. Does that make sense? Okay. So this is really being considered a reduced withdrawal to kind of get patients on it, especially when we talk about the outpatient setting. Our setting's a little bit easier because we have them in-house, but we have so many people that need treatment. I think if we can get something where people could do in an outpatient setting, especially now that we've removed that waiver, something like that could be really helpful to a lot of patients. So other considerations, what if a patient has to have surgery? What do you do if they're on buprenorphine, right? How do you take care of them? So if they're just gonna have mild to moderate acute pain from surgery, we're basically gonna either maybe continue that dose of buprenorphine, because buprenorphine is an opioid agonist. So opioid agonists, as you all know, oxycodone, hydrocodone, they're used for pain, right? So buprenorphine does provide some pain relief. So we can basically keep them on that dose, or we might need to increase it for a little bit. And then we obviously want to do and make sure they're also doing non-opioid pain modalities, physical therapy, right? Even ibuprofen, Tylenol, all those types of things. Side note, I will say none of our patients can obviously use opioids for pain, and we have a lot of patients with pain. But a lot of times I'll do Tylenol and ibuprofen together, and it works really well. And patients will be like, man, that really worked. So if you have patients that are struggling with pain management, a lot of times I'll actually do both if they don't have any reasoning not to have them. And then moderate to severe pain, so if they have planned surgery, if it's an extensive surgery, so my provider would actually, the recommendations say 2 to 4 weeks. He says he does it about 3 days. He's found that 3 days, buprenorphine just slowly kind of tapering quickly, actually is better results for him and the patient. So they're not having to have some washout period, like I talk about here, because then you have a high risk of relapse during that time, right? So really trying to just kind of taper off of it quickly, and then that full opioid agonist will occupy the receptors and provide that pain relief. If it's unplanned, you can actually give IV buprenorphine as well, and then you can discontinue and kind of do that cross overlap thing. So you're kind of doing it the opposite direction at this point. If you do that and you're giving more full agonists and less buprenorphine, you have to be really careful of overdose, right? Because eventually you might actually give too much too fast and you're occupying all those receptors with a full agonist response, which can cause that respiratory depression and the patient stop breathing. So big things I want to talk about. So this is kind of where we get into some of the stigma associated with buprenorphine specifically. But I wanted to call it extra medical use. I saw this actually in an article or a study that I was reading, and I was like, I really like that terminology. So what does extra medical mean? So it basically means use that's without a prescription, but realizing the user may have a medically driven reason for using the medication. So main reasons that they found in this review article were to self-medicate and achieve stability, so to prevent withdrawal, right? To prevent overdose. Right? So it helped people kind of reduce or completely stop the other opioid use. And then to manage ongoing use of other opioids and plan heroin breaks. So people, heroin can make their life so unmanageable that they might try to use buprenorphine for a while just to be able to stop the heroin, right? And then eventually, I would say the study talked about eventually they'll wind back up on heroin, okay? And then to get high. So that is potentially a reason for people to use buprenorphine. So I wanted to address this. So buprenorphine can cause a high. It is an opioid, right? So it does have opioid effects. So it can cause euphoria. It can cause people to experience like intense effects from it, right? But I will say for our patients and patients that are in recovery from things like heroin and fentanyl, it's not going to do much for them. Yeah, they might get a little high, but it's nothing like they're going to get with heroin or something like that, okay? So realizing that, yeah, it could cause a high, but most of the time, actually, in these studies, they're finding it's people that don't really use opioids that are getting a high off of buprenorphine, not people that are actively using heroin or fentanyl or something like that. It does have that ceiling effect, right? So we do see that ceiling effect on respiratory depression, on euphoria, all of that. So are people getting high off of buprenorphine? So multiple studies have actually shown that really ultimately it's not used to get high out there. Again, it would probably be the people that aren't actual heroin or people that have an opioid use disorder. It's not those people that are using it to get high. It's really a lot of times in this setting used by patients to manage withdrawal. So they're out on the street and they're withdrawing and that's all that they can get access to, right? So it's gonna help them, like we use it in the clinic, to help them prevent that withdrawal. It's gonna help maintain abstinence from other opioids when they can't find a prescriber. So not everybody has access to a prescriber and it's hard to get in to see a prescriber, an MAT prescriber. So they might be using it on the street to try to get off themselves and they're having to use it because they can't get access. As a self-detoxification plan, again, trying to get off of whatever opioid they're using themselves. Potentially because their current dose is inadequate, so this is why we talk about building a trusting relationship. We'll talk about in a second, but if a patient feels that it's not preventing cravings, or maybe they have a significant pain issue and it's not helping with their pain, that's whenever we have to talk about increasing the dose, right? Versus them having to go out and get it somewhere else off the street. And then controlling ongoing drug use. Again, sometimes people use it, when they don't have access to their drug dealer, I guess you can call them. When they don't have access to them, they're able to use this in the meantime, so they're not just buying heroin from someone they don't know, which sounds crazy, but it's very common, right? And so we want them not to do that, because if they have a trusted person they're getting their drugs from, they're less likely to get overdose, all that kind of stuff, because they're not just buying it from somebody random. So what do we do when we think about extra medical use, and so people that potentially use it for other medical reasons, but maybe people that did actually use it and abuse it, right? Maybe they did crush it and snort it. What happens if they're doing that? So really this is where I would say we've really started to use a lot of Sublocade. So Sublocade is the injection, and again, you do it once a month. There is the implant as well that you could potentially use, but this is really helpful because you still see them once a month, so they still come into your clinic, they can still do counseling, they still do group, they do all of these things, but really they come in every month and get this injection. So ultimately, really, we kind of help with that transition onto something that they don't have to take every day, they don't have to think about it, right? There's no chance of people stealing it or them misusing it, because it's an injection once a month. Other things we can do is we can look at naltrexone injection as well. It's a great option for patients, especially those patients that really don't want to be on anything again. Naltrexone is a great option. So what happens if patient relapses while they're on buprenorphine? So if you are running a clinic and someone relapses, do you kick them out? Our clinic would say that's the last thing. We hardly ever kick anyone out, right? But we've built a relationship with our patients to where they can come in and they can say, hey, I used meth this last week. And so we can have a good discussion of like, okay, well, what led you to that, right? And like, what's going on in your life? Like, why did you feel like you needed to use meth? And I will tell you, I hear our providers call our patients all the time, and they're like, no, I care about you. I care about you. It's okay. It's okay that you used meth this week, but like, let's figure it out, right? Let's increase the amount of times you come in and see us. Let's have our assistant who works in our clinic call you every day, all those types of things. So the well-rounded care is going to be a huge piece for retaining clients and maintaining them on treatment if they need treatment. So patients should be on for as short as time as possible. So this is one of those things that I feel like I hear all the time. And I would say that in actuality, most providers, if it's, yes, we want people on it for as short as time as possible for the lowest dose as possible, right? Like that's always something we strive for. So you can, I wouldn't say, you know a good clinic by how they're working with their patients, right? And so if they're on a lower dose. So my friend Blair I talked about, she's on MAT, right? And she takes 4 milligrams a day, very low dose, but she does it just to help prevent cravings. And I talked to her about it the other day, and she and this is kind of one of my last slides, but talked about the stigma associated in the opioid community of people having to be on it. Like she was like, I think I need to come off of it. And I said, I don't, you've only been on it a year and you're doing really well. And she's like, yeah, sometimes I get really stressed at work and I think, man, I'm glad I'm still taking this. And I said, if you're still thinking that way, you still need to be on it, right? When you start to say, I feel really stressed, why am I on this? Then maybe that's a good idea to like step back and cut back on your dose. So I think really making sure we're individualizing this. It's not about like, oh, you only need to be on it for 6 months, right? Studies actually show if we can keep people on it for 12 to 18 months, we actually see better results. And that's because people can get their lives back. They can get a job. They maybe get a car, right? They can get their kids back. They have support systems. They have all of these things within a year versus you've been out for 3 months and everybody's telling you need to get off of it, right? And most providers actually don't encourage people to get off of it right away, right? Now, if they're continuing to go up and up and up on the dose and never coming down, you know, and you'll, as a pharmacist, I've had patients that come in and say, I want to decrease my dose, but the provider won't let me decrease the dose and everything's going really well. Like that is more of a red flag versus, well, you're still in chaos right now, right? Like life is chaotic, so maybe we should continue on this dose. All right, so you're seeing a patient once monthly for buprenorphine treatment. They test positive on their urine drug assay for methamphetamine. They tell you they've used it twice along with bup over the past 2 weeks. Which of the following is the best direction to go in this patient? A, discharge them from the clinic. B, send them to inpatient treatment. C, discontinue buprenorphine treatment. Or D, identify reason and increase frequency of visits. D, I made both my answers D. So yeah, a terrible teacher, okay? But yeah, identify reason and increase the frequency of visits. Again, like this is not about shame and guilt. This is the last thing they need to feel, right? And I will say like conversations I have with patients, like that's where they're at when this happens. It's not like, oh, I had a great time, you know? It's like, no, I feel terrible. I can't believe I did that. What am I thinking? Like, am I gonna lose my kids again? You know, and it's like, whoa, no, stop. Like, let's come in, let's talk about it, or let's talk about it on the phone, whatever. Let's start meeting. We had stretched it out to once a month. Why don't you come back every 2 weeks and let's start meeting every 2 weeks again, right? And so making sure that we're really working with those patients. All right, so building a trusting relationship with patients. Any of you all that are providers in here probably know a lot about this, but I think when we talk about it in regard to addiction, I think it's pertinent to providing the best possible care because people have to trust you to be able to tell you when they messed up, right? Otherwise, it's not gonna go well. So building a trusting relationship, empathy, so knowing yourself and your history with addiction. So I think this is one of the big areas that I feel like I see in people potentially that I kind of find like maybe they could work on their empathy a little bit, right? But I think a lot of times it stems from some type of personal relationship they had with addiction, maybe a family member, something like that, where it's just really biased them towards their patients or patients they're serving. So really knowing your own history and like reflecting on that. And honestly, like if you just don't have it in you to work with people with addiction, or you really struggle with it, or you just don't feel much compassion for it, just don't go into it, right? There are plenty of other health, and that sounds really harsh, but like there are plenty of other areas in the healthcare world that you can go into, right? So if you feel compelled to do it, right? But do it well, and worry, and I guess like I talked about earlier, form a personal experience with people outside of your clinic, because that gives you a good view, a bird's eye view, I guess, of a lot of the things your patients are going to struggle with. And it gives you an understanding of like, well, of course they would relapse, or of course they're using because of their trauma. Like when I hear my patients' stories, I'll always think, I mean, if I had that story, I'd probably be using drugs too. Like there's no doubt, right? So really understanding and knowing yourself. Making sure that you do educate yourself on substance use disorder. Like, what is it? What does it do to the brain, right? Like, how does trauma impact it? How do adverse childhood experiences, or ACE, have you guys heard of ACEs? How does that impact your idea of addiction? And then be aware of your role and how you carry yourself. I think that's huge, right? If you have this, if they call you and you're just like, oh, okay, well, you screwed up, like, you know? But if you're like, it's okay, like, I'm a mom too, right? Like life is hard, it's not easy. I can't imagine being a single mom, right? Like, so talking to them and like helping them understand that you're also human and you also make mistakes, I think is a huge piece of it, that you're just not a healthcare professional. You're also human. And then identify what you're responsible for. So I'm not saying that everybody has to be pushed through, right? Like, yes, like you can be loving, very loving, but you can also be firm. And a lot of times people that are struggling with addiction, they need boundaries. And they'll all tell you that. All my patients will say that, boundaries. You need to give me boundaries. That's why we have boundaries in sober living facilities and in our facility, right? Like we have things that like help them move forward. And then have humility and accept them as they are, just as Jesus accepts us as who we are, right? Like we all screw up, and ultimately like we're all in the same boat, just in different areas. And so really having humility and understanding and like true care about where they're at. Again, a trust-based relationship, so they know, so that they tell you when they're struggling. I don't know how to stress that more, but like letting them know you're human, you screw up, so like tell me when you mess up. You know, that's how we're going to get you better. And then stay alert to what informs your opinions. I think social media, friends, family, people around you, stuff they say can really impact your view on how you view your patients and how you view addiction. So realizing what you're putting in is potentially going to somehow, whether it's unconscious or conscious, come out. Invite them into your community. I think that's a huge piece. I always am telling patients, you should come to my church, right? Like, when you get out, come to my church. I told one yesterday, actually. She was like, I'm getting out tomorrow, and I'm going to be with my mom. And I was like, yay! And she's like, I don't know how it's going to go. My daughter's not happy with me, you know? And I was like, it's going to be okay. Like, just take deep breaths. You know, she said, but I'm coming to your church. And I said, good. I hope to see you there, you know? And I've told her probably 15 times where my church is. So hopefully she actually shows up, right? But at our church, we do have a lot of people in recovery. And so I think that's a good place for people to be, is around other people that are in recovery. And if you see somebody that comes into your church or they talk about being in recovery, like, please reach out to them. It takes so much for them to be there. But really making sure that you bring them into that community space with you. They need to be around people that are not also in addiction. That's the problem, is a lot of their circles are people that are also have or were using, right? And so it's good for them to be outside of those boundaries. Just as all of us, it's good for us to be outside of our normal. And then pray for your patient or with your patient. I pray with a lot of my patients, right? And ask them questions. And, you know, in the addiction world, that everyone has a higher power. That's what they say. So I think really making sure you talk to them. I love talking to patients about Jesus and asking them if they believe in Jesus, or having conversations about that. That's one of my favorite parts of my job. being able to do that with my patients, because ultimately that's what's going to heal them, right? Is them surrendering to Jesus and allowing him to kind of walk with them through what they're going to have to walk through when they actually come into recovery. Motivational interviewing is a huge piece in addiction. Has everybody done motivational interviewing? So I'm not going to like belabor this point, but obviously realizing where your patient is in regard to addiction and their substance use. So are they like not at all wanting to get in recovery? Great. They might be in pre-contemplation, not even really thinking about it, right? Or are they like fully in recovery and in maintaining? Where are they at on that scale? And there's a really great website. So using motivational interviewing and substance use disorder on the SAMHSA website. So I put those links on here. And I think the slideshow, is it posted? I can't remember. Anyways, I'll make sure it gets posted or you guys can get it or you can email me. But these are really, really great resources for kind of helping your patients kind of process and motivate them to move from one area to the other. So again, just basically talking about that. I think the biggest piece, obviously, with any type of motivational interviewing is that intrinsic piece. Like, they want to do it for themselves. It's not somebody else telling them. It's not them doing it for their kid. It's them doing it because they want to do it for their own life. And then slips, so again, something to expect. So I would say if you're gonna work in the addiction world, realize that like, this is a very big part of the addiction world, right? So understanding that like all of these different risk factors impact a patient slipping, right? I think my biggest point on this is trashing the shame and guilt. It really doesn't help in this population, ever, ever, ever. So the last thing you can do is make a patient feel bad that they've slipped up. Being kind, being caring, listening, right? Not talking and just letting them listen is a huge piece to helping people in recovery. So what patients can do, so what do they do when they have a relapse? I tell them the first thing that they need to do is reach out for help, right? Like, reach out to someone and say, dude, I screwed up. Attend the best NA or AA group for them. I have patients that come like, oh, I went to that group and it was terrible. I didn't like it, right? Have them try another group, you know, especially if they're early in recovery. If they're early in recovery, NA and AA can be so helpful showing up somewhere every single day, right? I'm not saying that it's always going to be the case, but like I would say, especially in early recovery, it's super, super helpful. Avoiding triggers, that's a huge one. You know, if they tell you, well, I always go here and then it happens. Well, let's talk about not going there, right? Or not doing this, because that's what you're saying is like making you want to use. Sorry. Setting boundaries. So again, most of my patients will say like, I need boundaries. So having them set their own boundaries, like that's part of it. Like, what led you here to this relapse? What boundaries do you need to set for yourself next time, right? And having them reflect on that. Practicing self-care, as we all need to do, right? Taking care of yourself as well. Like, if you don't take care of yourself, then you're gonna wind up in a relapse. So we have patients that like, they get out and they've been doing really well for years, and then it's all of a sudden it's like their whole life is spent doing their job and taking care of their kids, and there's no self-care. They stop going to groups, they stop going to church, whatever it is, right? They're not doing any self-care, so that's a huge piece of it. Making sure, again, they reflect on that relapse, again, to help set boundaries and kind of have an idea of what to do in the future. And then develop a plan. So recognizing boundaries, recognizing triggers. What am I gonna do? What am I gonna do if this happens? Who am I gonna call, right? Like, what is it gonna look like for me? And then what professionals can do to assist with the relapse. So do we need to refer them back to treatment? Like, is it a full-blown relapse, or was it just like a once or twice thing, right? Like, what does it look like? Do we need to have them go back into inpatient treatment? Can we work with them out in the outpatient setting? Do we need to have increased counseling? Do we need increased drug screens for the patient? How about increased MAT appointments? Being really cautious with like our nonverbals. So maybe we're not saying, oh, we're really disappointed in you, but like our face is like, oh man, you know, like watch your nonverbals. Lovingly hold accountable. Again, patients want boundaries, just like all of our children. They want boundaries, right? They don't realize it. But lovingly hold them accountable, right? Like making sure that like I love you, but I'm also gonna like have you set these boundaries. You're not recognizing you need to set it as a boundary, but like let's set this boundary together. So yes, you're self-reflecting, but maybe I can help you as your healthcare professional and friend that I've been seeing for a year that like we need to maybe make sure you don't call this guy again. Like how can we make sure this doesn't happen? Be direct and clear of expectations. Make sure that you're letting them know and being direct about it. If you're just kind of like, oh, well, maybe don't do that, or maybe, like that's not helpful for patients. Being very clear with them. And then ultimately, like if all else fails and like you've tried and they're continuing to relapse and they don't want treatment and they don't want help, all that kind of stuff, that's whenever we think about like, okay, like we're not in the right space or time right now that like you're ready at all. So we will have to discharge you from our clinic. But if you're ready for recovery, come back in at the next door. We can come on back in and we'll probably get you ready to go again, right? Whenever you're ready. So the last thing I wanted to talk about is what is success for a patient. And I think this is a really interesting, it was an article, and it interviewed like, I think around 20 physicians and then 20 to 40 patients, I can't remember. But I thought it was really, really interesting to see the 7 themes of success that emerged after all these interviews with both healthcare professionals and providers and then patients. But staying sober was an area of success. Taking steps to improve physical and mental health. So when patients were actually like taking care of themselves, right? And out getting a job and trying to improve like exercise and doing things that were like outside of what they normally did. That was a theme of success. Improve psychological well-being, right? Like when they said about themselves, like, I feel good, like, this is great, like, I feel like I'm doing a good job. Like that was a theme of success. Improved relationships, so healing a lot of the broken relationships that might be in their life. Improved role functioning, so are they able to be a mom again, right, or a dad, a sister, brother, whatever. Are they able to do those types of things? And then the last 2 I thought were interesting. So physicians didn't actually find them as didn't define these as success in their interviews, but patients did. So patients had this internal stigma for themselves that really like led into like, also, I need to be tapered off buprenorphine, right? This is an area of success. Physicians might say, I don't feel like they were ready to be tapered off yet because everything was really chaotic in their life. So like that's not an area, like them to become completely off isn't success to us. Like success to us is like, they have all of these other things, right? Yes, like maybe they could come off, maybe they couldn't, but like that's not an area of success. But for patients, getting off of it was what they viewed as success for themselves. And again, that decreased internal stigma and shame. And that fell along with, I'm still on something, right? I'm still on something that's a controlled substance and still helping me. That kind of fell into that same realm. But yeah. So as you think about your relationship with people struggling with substance use disorder, in what ways can you help build trust between you and them? Something to ponder on. And me to knock this down. What questions do you all have? Anything? Yeah.
What are you seeing as the switch to polysubstance kind of moved away from heroin or fentanyl or crystal methamphetamine? And I noticed that you had in the slide that some of the interactions between benzodiazepine and cannabis, we're seeing so much vaping and THC levels so high. How is that changing the way that you're navigating some of the medications for the patients that you see? We're seeing it to be complex, and then on top of that, getting mental health medications that need to be put in the mix too. What's some of your thoughts on that?
You mean in like drug interaction realm, or you mean just?
How are you navigating in terms of educating the patient and then, kind of being able to bring that balance in that in both the inpatient and then eventually in the outpatient setting where you've got somebody that's been historically maybe not, that don't manage their medication appropriately, and now I've got kind of a complex interaction thing going on. How do you help so that they stay on track? Does that make sense?
A little bit. So if they're on if they're using, so in our outpatient clinic, typically they're on buprenorphine, right? Or Sublocade, injection, oral. We have naltrexone as well. So I would say we definitely, even whenever, I actually recorded this presentation with the physician I work with, and we were talking about that patient with the meth use, and he was like, hey, I just had this happen today, So it's I would say it's actually common. And so I honestly think it goes back to like that relationship with them, like them being able to tell you, and you saying like, okay, what does that look like? So it might be like, we need to go up on your dose because you're having cravings that we didn't realize you were having. And so really trying to kind of address that. Now, I mean, it's a hard boat because you also have to talk about the marijuana and all that kind of stuff. And so, people are on buprenorphine, but they might still be using marijuana. So I think it comes down to like, are people really, really ready for recovery? And if they're not, it's okay that they're still on buprenorphine. And it's preventing them from using IV heroin, fentanyl, right? No, do I disagree? Do I think that they should be out smoking marijuana? No, but at the same time, if they're using buprenorphine and smoking marijuana and they're still able to maintain a job and they're not overdosing, I think there's that big piece of preventing death. We're still preventing death, and they're not ready, but hopefully when they come in and see me every week, because at this point I'm probably making them see me every week, hopefully when they come and see us every week, that we're building some type of relationship, so at some point they're gonna actually step into this wait, why am I smoking? Why am I smoking marijuana, right? I actually want to do well and I want recovery. I don't know if that helps.
No, it helps a lot. And one just follow-up question. What's your take? I mean, we're seeing East Coast conversations around, they call it safe, supervised injection as this alternative, which to me, it's so counterintuitive to where we're trying to take people to that place of recovery. What's your thoughts about that?
Man, you're bringing a whole ethical conversation here.
It just keeps coming up.
So I'm going to be on the to be honest, I'm on the let's just save people boat. So I think for me, I believe the safe injection sites are a really great idea. I think that it provides a point of contact for people so people can come in, and hopefully we're not just letting them use hey, you can come in here, but at the same time I'm gonna hang out and talk with you, let's hang out and chat about life. And then obviously if they're overdosing in front of you, we're saving them. And then I even think about that increases our chance of hey, you're coming in here all the time to use heroin or fentanyl. Let's talk about buprenorphine. Why can't, let's get you transitioned. Again, maybe we'll get you transitioned and maybe you'll smoke weed with it too, but at least we have you on something that's not increasing your risk of overdose and hopefully allowing you to have a better quality of life and get back on your feet, right? And it's not this up and down heroin fentanyl thing. It's more controlled and we know what's kind of happening with it. So personally, I have thought a lot about it and I actually I do think that it can be really helpful. And honestly, to be honest, I always think it go back to my personal, if Blair or Robin was to start using again and they are gonna go, would I rather them use in some random trailer or would I under the bridge, or would I rather them go to a safe injection site where I know if at least they overdose, somebody would save them? 100% I would say a safe injection site.
Thank you for that.
Yeah.
I'm always interested.
Yeah. That's a big ethical conversation, though. I'll throw that out there. We have a whole session with our pharmacy students, one whole class period, just to talk about this. It's very interesting. So, I think as Christians, lastly, I think as Christians and people that love Jesus, we have to see everyone is made in His image. So, we don't know what's gone on behind. Previously in the patient's life. So to make judgment calls and stuff, sometimes I can't get there. I just want to help people and I want to save them so that hopefully they can at some point, they want to make a decision to say no, I really want to kick this and I really want to do it. It's like Blair, this time around, she has said she said, I thought about meth the other day and I got super nauseous. It almost made me want to throw up. I've never heard her say that. And when she said that, I was that's really good. But she's 38 years old, 38. And she's finally I feel hopefully, hopefully she is there. Like she's done with it. She acts like it. Her whole mindset has changed, you know, but it's taken her 38 years, 13 times in treatment, or 15, I guess. So, any other thoughts? Y'all feel free to email me if you have questions. And if you have like specific questions for providers, my providers are amazing and they really, really do a really good job taking care of patients. You know, so, thank y'all.
If any of you need CEs for mental health professionals or teaching professionals, please make sure you sign in.
Is April still there?
April Barnes? She is still there. I actually saw her in the hall yesterday and I was gonna be like, hi, but I didn't get to talk to her.